Good morning. My name's James Danger, and this is the second of several videos I plan to make on pre-eclampsia and IVF. It's all based around an article published in Human Reproduction Updates in 2023, the obstetric and neonatal outcomes after natural versus artificial cycle, frozen embryo transfer, and the role of luteal phase support as systematic review and meta-analysis. The object of this project was to determine whether natural cycle FET, with or without luteal phase support, decreases the risk of adverse obstetric and neonatal outcomes compared to artificial cycle FETs. So, so this was basically following on from a video I made just recently looking at oocyte donation, and also meta-analysis looking at oocyte donation in natural conceptions in IVF, where they argued that the prevalence of pre-eclampsia after oocyte donation was 4 to 5 times higher than natural conceptions and 2 to 3 times higher than after IVF with a couple's own gametes. So two views on pre-eclampsia. One is that although the pathophysiology of pre-eclampsia is poorly understood, both in natural as well as in medically assisted pregnancy, such as oocyte donation, it is suggested that the higher incidence of pre-eclampsia in ovum donation is due to the fact that the transferred embryos are completely allergenic to the recipient. Just excuse me for a sec. But it's a general rule in the general population, pre-eclampsia develops in 2 to 8% of all pregnancies. It can be classified as mild, severe early onset, and especially severe early onset preeclampsia bear the risks of high maternal morbidity, perinatal death, and severe neonatal morbidity, resulting in a worldwide annual death rate of 70,000 women and 500,000 infants. I find that almost inconceivable to believe, but that's what was reported. It affects all the oocyte donation cycles, fertility preservation cycles, embryo donation cycles, and surrogate cycles, but it may even affect all FET cycles. And even last year, the authors were still arguing that egg donation, gestational surrogacy, the pregnancy risk is a lot higher because it's an unrelated embryo to the couple. So they argue that pregnancy using egg donors or gestational surrogates carries greater risk, that is where the embryo is unrelated to the carrier. The hypertensive disorders and the various placental pathologies are more likely in young and healthy carriers of unrelated embryos. Surrogates and egg donors should be told of the increased risk they face compared to other similar fertile young women. So really the argument, as I saw it, was that with ovum donation, even though the pathophysiology is poorly understood, it is suggested the higher incidence of preeclampsia and ovum donation is due to the fact that the transferred embryos are completely allergenic, that is totally different to the recipient. However, there is another view to say that the type of FET cycle may influence the neonatal outcome. Attention has been focused lately on whether artificial cycles are the same as natural FET cycles. Rather than being an allergenic issue, maybe the argument that it relates to whether the FET cycle has the functions of corpus luteum as in natural cycles. And remember, there's no corpus luteum in artificial cycle. Therefore, it just may be a vascular issue. And the reason it's important is this graph. For a long time, the proportion of fresh to frozen transfers was about 10% frozen, but from about 10 years ago, it started to rise. This is data presented only several weeks ago, but only for the data for up to 2000. That's a huge delay. But we now believe, excuse me, that the rise of FETs is becoming exponential and may well even be more than fresh transfers. And that's largely because of the use of pre-implantation genetic diagnosis for aneuploidy has been vigorously implemented at a much higher rate than anticipated, particularly in the last 3 or 4 years. And nearly all those transfers, the embryos that have been frozen and then checked and then put back, will go back into artificial cycles. But the data is not always collected on whether they are artificial or natural cycles. Therefore, a rise in preeclampsia may go unnoticed for a long period, even though a number of articles have reported this risk. It has the potential to become a serious issue for ART programs if it's unrelated to oocyte donation, but more to the fact that they are artificial cycles. So now is the time to ask is there any data to support that artificial cycles may lead to higher rates of preeclampsia as an alternative to the argument that is caused as an immunological reaction and like an allergenic reason. And since artificial cycles do not produce a corpus luteum, are there factors missing that may lead to an increased risk of preeclampsia? Well, there have been many publications suggesting FETs artificial reed and embryo cycles lead to macrosomia and heavier babies than normal in IVF. And does this data explain the risk of preeclampsia with oocyte donation? And once again, I'll come back to the article in question. And in this article, the authors, the bakers argued that the number of frozen embryo transfers has increased dramatically over the past decade. Based on current evidence, there is no difference in the pregnancy rate when natural cycle is compared to artificial cycles in subfertile women. However, natural cycle FET seems to be associated with a significantly lower risk of adverse obstetrics and neonatal outcomes compared to artificial cycles. These risks include preeclampsia, but are also more closely focused on macrosomia and large birth weight babies. So currently, there is no consensus about whether natural cycle FETs need to be combined with luteal phase support or not. And the question of how to prepare the endometrium for FET has now gained even more importance and taken on the dimension of safety into account as it not simply be reduced to the basic question of effectiveness. This paper changes the study population from oocyte donation to FET endometrial management. So in the study, they looked at a number of papers and they've isolated 30 that they could include in their meta-analysis. And even though this isn't the main topic about preeclampsia, their focus was on birth weight and preterm, which is a real concern for artificial cycles. And in their meta-analysis, they could demonstrate that there was an increased incidence of higher birth weights in artificial cycles than in natural conception cycles, particularly if there was luteal phase support given, as you would expect in artificial cycles. And also there was a tendency towards lower preterm births in artificial cycles compared to natural cycles. So this meta-analysis was confirming the fears that a lot of people had that FET cycles, artificial cycles, were associated with heavier babies and early preterm. But this is the table I wanted to present. This is the analysis of neonatal outcomes compared to artificial cycles compared to natural cycles. And even though there was a support for macrosomia and large birth weights and large gestational age, there was an increase in preterm births. There was an increase in hypertensive disorders of pregnancy. And here's the data that I was after. Preeclampsia was significantly higher in artificial cycles compared to natural conception cycles, irrespective of whether this was ovum donation or not. And the other thing which I caught my eye was this increase in postpartum hemorrhage, which is significantly higher in artificial conception cycles. And this has been linked to gestational surrogacy and ovum donation cycles as another risk factor apart from preeclampsia. It's interesting that congenital malformations were not different between the two, although I noticed that there is this trend towards increased risk for artificial cycles, and maybe that does need to be looked at in future papers. So the author produced nice little graphic. You do the IVF, you make the embryos, put them in the fridge, thaw them out one by one after testing. And if you turn them back to the client, in a natural cycle, they argue that it's more safe for mother and child with a normal birth weight, less preeclampsia, hypertension, postpartum hemorrhage, and preterm births. And if you add luteal support to the natural cycle, you may even lower the preterm birth incidence as well. And they basically just said that artificial cycles are less safe relative to natural cycles. So the wider implications of this is, there's a lot of repetition in this video, I apologize. This study confirms that natural cycle FET decreased the risk of adverse obstetrics and neonatal outcomes. They estimated that for each adverse outcome, if they had used natural cycle FETs, it would have prevented 4 to 22 cases per 1,000 women. Consequently, they are arguing that natural cycle FET should be the preferred treatment in women undergoing ovulatory cycles having FET. That is, women that can ovulate, they should use a natural cycle rather than artificial ones. And based on very low quality of evidence, the risk of preterm birth may be decreased if the luteal phase support is also given. And I'd just like to read out the summary that the authors made in their paper, and so I'm quoting from them, but it summarises the information very succinctly. The association between the endometrial preparation methods for FET and the obstetrics and neonatal complications merit further attention and awareness in clinical practice in order to optimise the health of both mothers and children after FET. It's been more than 30 years since the first baby was conceived after FET, and from the start it was performed in an artificially prepared endometrium because his first application was in fresh donation cycle. Be quiet, phone. Their solution for women without oocytes was to apply an artificial cycle to grow the endometrium in which the natural hormones, as produced in ovulatory women by corpus luteum, are partially substituted with estrogen pills and progesterone vaginal capsules. And then the important point is that artificial conception cycles have been very reliable, effective, and predictable protocol for fertility laboratories, and therefore is still highly popular in FET in ovulatory women. However, the authors argue the time has come to reevaluate its use. Many studies, including their own meta-analysis, have reported an increased risk for mother and child in artificial conception cycles compared to natural conception cycles. The advantages excuse me, probably make you go deaf. The advantage of artificial conception cycle nowadays is the easy alignment of the time point for thawing and transferring embryos within organisational necessities of the IVF laboratory, the treating doctors and the patient. But these do not necessarily outweigh the disadvantages in terms of adverse obstetrics and neonatal outcomes. This data on safety outcomes suggests that natural cycle FETs are preferred over artificial cycles. And they make the comment that natural cycles in combination with luteal phase support should be considered. It may be beneficial in terms of pregnancy rates, although it did not result in worse safety outcomes and might just result in lower preterm births. And they make the point that this recommendation does not concern anovulatory women that do require artificial cycles. There were a rebuttal to this paper produced a week later, where the authors suggested that in fact artificial cycles are so well embedded within IVF cycles that they can't really do away with them, and the management of natural cycles is so disruptive that it makes it really difficult to behave. And they argued that what they should be is more attention focused on identifying the people at risks. And the authors replied that that may be so, but that you can manage natural cycle FETs with very little impact and considerably less cost to the couple than otherwise may occur. So they still argued that natural cycle FETs should be considered. So my comments in the last couple of minutes is that many clinics now routinely culture embryos to the blastocyst stage and biopsy for PGTA and aneuploid testing. This necessitates embryo cryopreservation and multiple FETs. Busy clinics use artificial conception management cycles to cope with demand, and natural cycle FETs is virtually not an option. I think I need a beer. Regardless of the neonatal risk, clinics will not abandon artificial cycles. They're so busy and so well embedded into practice that they will not abandon it. They'll have to find a way around it. But I can't see at the moment any further publications on the risks associated with artificial conception FET cycles. If there are, please list them in the comments and I'll do another video on them. So at the very least, if I was a partner of someone going through IVF, I would think that couples do need to be counseled about the risk of the neonatal risk, including that of pre-eclampsia. And ovulating women should at least be given the option of doing natural cycle IVF, even if there is an additional cost or whatever. But I would think that it would be reasonable in a couple workup that they be reviewed clinically for the risk of preeclampsia and other obstetric adverse outcomes, and treatment to minimise risks such as single embryo transfers be clearly identified in their management. But I think this is becoming a growing issue for IVF, particularly as more and more cycles are done as FET in artificial conception cycles. It's almost certainly the majority of cycles now. The clinics and the obstetric management need to be more integrated. I think for a lot of cases, after the clinic has achieved the pregnancy, the couples are returned to their own obstetrician, and it may well be that the clinic doesn't focus on the outcome as much as they possibly should. But I would think it's wise, having this information now available, that clinics ensure that they keep in touch with the outcome of all FET births, and to make sure they are reviewed as part of their KPI management at the board level. And data collection systems need to request the type of FET management and neonatal outcomes for future assessments review to ensure that this risk is not getting out of hand. So my comment is the risk of preeclampsia after oocyte donation transfers due to the nature of the embryos being transferred or due to the widespread use of artificial FET cycles? I think the data remains unclear, and it may well be both issues. Does the impact of artificial cycles on neonatal outcomes explain the observed increase in preeclampsia? At the moment, that needs to be published to review, looked at specifically. There needs to be a meta-analysis where they are separated between natural cycles and artificial cycles, and oocyte donation or allogenic transfers and non-allogenic transfers. And I think my next video on this topic will look at the role of the corpus luteum and other risk factors for preeclampsia using IVF. So I'd just like to finish. So my name's James Stanger. I'm not a medical person, but this information is not medical advice, but may help you in knowing what questions to ask and maybe help in understanding the advice you receive. If you like, please subscribe or click like. And I'd just like to have a quick plug for my FET website, which is an online EQA and training program in andrology and embryology. And at that point, I'd like to say goodbye and au revoir.